Hello, my name is Nikon Shrivabadi, a student physical therapist from the University of St. Augustine for Health Sciences in San Marcos, California. Today I'm going to present to you a case on chronic low back pain. According to Rundle et al. From the Journal of Physical Therapy in 2018, low back pain is the most common work disabling injury in the United States and affects about 80% of our population. The purpose of this presentation is to explain to you some of the impairments that may result from a low back related injury, link those to how they may affect daily function, and finally discuss the evidence-informed treatment plan for each of the impairments that were found during the evaluation. So my patient is a 63-year-old man, mesomorphic build, right-hand dominant, and retired engineer. His chief complaint is stiffness in the lumbar spine, dull ache in the right lumbar region, and an occasional crippling flare-up from the right lumbar spine to the right gluteal region to the posterior thigh and lateral leg. He claims that these symptoms arose after a long day of digging holes in the backyard to plant some trees, while doing repetitive bending, lifting, and twisting motions. This happened about 17 years ago. My patient claims that the flare-ups occur when he's overworked and leaves no time for resting, and he does his best to avoid that. He has gone to a variety of rehabilitation approaches, such as chiropractic and acupuncture therapy, used over-the-counter medicine to alleviate the constant pain, but none of these have any long-term success. He has seen his primary care physician in the past, but never diagnosed to his knowledge, and has been sent to conservative management when which he claims is a few sessions of physical therapy, but the only thing that relieved his symptoms were just resting. The numerical pain rating scale was used to quantify my patient's pain. The NPRS ranged from 0 to having no pain and 10 having the worst imaginable pain. Currently he's at a 3, at best a 0, and at worst an 8. Things that made his pain worse were overexertion activities such as gardening or anything that made his trunk fatigue. The only thing that made his pain better, to be honest, was just resting and laying in bed. According to Algadir et al. From the Journal of Pain Research in 2018, the NRPS had an excellent inter-rater reliability and validity. For this scale, we'll be looking for a 2-point change for the minimal clinically important difference. The medication he's currently taking is aspirin, statins for cholesterol, and medication for his prostate and blood pressure, which is well controlled. His prior level of function consists of 2 to 3 hours of constant yard work without fatigue, walking the dog around the neighborhood with no pain. His goal is to improve his tolerance to exercise and continue his hobby of gardening with no pain or range of motion deficits and reduce low back pain and occurrence of the flare-ups. I use the Oswestry Low Back Pain Disability Questionnaire, as this outcome measure is a patient-completed questionnaire that gives subjective percentage scores of levels of function of specific activities of daily living for people who are rehabbing from a low back pain. This scale ranges from 0 to 5, with the lower score indicating no disability and higher being bedridden and fully disabled. My patient is currently scored at a 26, which falls under moderate disability. During his intense flare-up, which occurred maybe a few times a year, at a 74%, which falls under crippled. And during his more common flare-ups that he has, it's at 54%, which is severely disabled. According to Mikasic et al. From the Spine Journal of Philadelphia in 2013, the outcome measure has excellent test-retest reliability and validity, with a 12.8% change in score for the minimum clinically important difference. Structurally, my patient presented with rounded shoulders, neutral pelvis, and standing with his right iliac crest inferior to his left. He also sits in a posterior pelvic tilt. For active range of motion, he was limited at about 60% in forward flexion as he deviated to the right and then pain comes about. Left side bending and right rotation were also limited at 50%. His extension was limited, but mainly due to poor motor control. Right side bend and left rotation were within normal limits, but he complained about stiffness during all these motions. We did muscle palpation which revealed some increased tone in bilateral paraspinal muscles and limited musculature in the gluteal region. There was also noted excess adipose tissue in the abdominal region. When conducting a passive range segmental mobility test, I found a few hypomobile segments and a hypermobile segment. Hypomobility was found on the right at the L4-5 segment and the 5-1 S1 segment, both with grades of 2. As for the hypermobility at the L3-4 segment, which is a grade of 4. The neurovascular screen was noted to be unremarkable with the exception of bilateral hip flexor weakness, both receiving a grade of 3+ out of 5. The lower quarter assessment revealed some tightness in bilateral hamstrings and weakness in bilateral hip flexors as previously stated. No diagnostic testing was performed at this time. We did some special tests to rule in and rule out any possibilities of contributing factors. Straight leg raise was done in supine position with the testing, lower extremity knee extended. Lower extremity leg was passively raised into hip flexion to assess neurological tissues and their sensitivity to mechanical stress. Symptoms came about at the testing leg at about 48 degrees, which might suggest a disc herniation affecting nerve roots L4 through S1, possibly. Slump test was also done by slowly progressively taking the patient through neural tensioning to assess the neural tension sensitivity, in this case reproducing our patient's symptoms. The patient was seated with legs off the edge of the table in a slump posture with overpressure into cervical flexion and thoracic extension. The lower extremity was flexed at the hip while keeping the lower extremity knee extended, and then he was told to dorsiflex the ankle. In our case, the symptoms came about right at the time of the dorsiflexion, which he was directed to flex the knee, and then symptoms were resolved, thus indicating a positive test. Supine assist test was also done to assess whether the structural observation I made earlier was due to a structural leg length discrepancy or functional. The patient was in a supine position where the legs were flexed for his knees to go to his chest to neutralize the pelvis, and then the legs were extended and measured the assessment side by side. Then the patient was instructed to sit on up, and then I would assess the legs again, and it was noted that the leg was longer in sitting and shorter in supine, which resulted in a posterior torsion of the ilium on the sacrum. All other sacroiliac joint special tests were unremarkable. We did a movement analysis to measure his gait and analyze that. And during initial contact of the right lower extremity, the patient had some discomfort, and then I noted short stride length bilaterally. The patient also exhibited pain with forward bending at the hips and knees, supine knees to chest. The PT diagnosis using the International Classification for Function, we would classify this patient as low back pain with mobility deficits and chronic low back pain with radiating pain with an ICD-10 billable code of M54.4 for low back pain. The long-term goal for this would be 4 weeks, and the patient would restore full range of motion to improve strength of local muscle stabilizers in order to carry out desired activity level of guarding with 0 out of 10 pain for an extended period of time for the physical therapy long-term goal. Impairment list. I would first like to target the hypomobility at the L4-5 and L5-S1 segment, doing a posterior and anterior mobilization with a grade 3. Shum et al. At 2013 from American Conference of Rehab Medicine concluded that there's immediate effects on reducing back pain, stiffness, and range of motion in the lumbar spine. We could also do a positional distraction without rotation during the flare-ups to possibly try to open up some of the facets on the right side and alleviate any pain the patient may have. Next, I would like to target the hypermobility of L3-4 by doing motor control exercises for the multifidus and transverse abdominis. Costa et al. From the Journal of Physical Therapy of Science in 2016 did a study with interventions of these motor control exercises, comparing those to therapeutic modalities, and there are significant improvements in favor of the motor control group for activity tolerance and global impression of recovery. Next, I'd like to target the posterior torsion of the right ilium on the sacrum by doing an anterior torsion, high velocity, low amplitude manipulation. Gong et al. In 2011 from the Journal of Physical Therapy of Sciences performed prone anterior torsion manipulation that I listed with people with 10 millimeter functional leg length inequality 3 times a week for 12 weeks and saw about a 9 millimeter improvement on the experimental group. Next, I'd like to target the bilateral hamstring tightness by doing hamstring stretching of an antagonist hold. Lee et al. In 2017 of the Journal of Physical Therapy of Science concluded a study from patients with low back pain showed significant difference in pain level, pressure threshold, and disorder index of low back pain. Next, I would like to do some nerve mobilizations, and with that, I would be doing a slump stretching. Cleland et al. Of the Journal of Manual Therapy in 2016 completed a study with patients with low back pain and that complained of symptoms distal to the buttocks and had pain during the slump, symptoms during the slump, and they did slump stretching with some exercises. After 6 sessions, that group felt pretty good. They had overall decreased perception of pain and reduced disability. Next, I'd like to target the hypertonic paraspinals, doing some soft tissue and trigger point treatment. After that, 1 joint hip flexors that were weak, I would be doing some standing marches and then progressing that to weighted marches with ankle weights. Finally, some patient education to educate the patient on the importance of an active lifestyle, incorporating progressive low-intensity sub-maximal fitness and endurance activities and postural awareness. Finally, the prognosis of the patient would be poor due to being a 63-year-old male with a 43-year-old smoking career, sedentary lifestyle, and slightly overweight, and he has low motivation for rehab. To summarize, the patient's body has created a mechanism to prevent further tissue damage by preventing motion at the lower segments due to a possible chronic disc injury, therefore making up for motion at the segment above. The symptoms of my patient are aggravated with increased repetitive activity, thus benefiting from improving the tolerance of the spine's local musculature to stabilize during all activities. Chronic low back pain comes in a variety of diagnoses and symptoms, thus important for all physical therapists to be able to pull all the impairments found during an evaluation to get to the root of the problem, as low back pain patients will be very common. This is an example of how to develop an evidence-based program on an individual's impairment and patient's goals. Thank you for listening to my presentation, and I'll take time to answer any questions.